The Brain and Mind Institute has a vision, and the vision is that we do not deal with the brain as just this organ. It is also the organ that not only makes us move and walk and talk, but also think and love and feel. So we wanted to bring together all of the people whose research activity is relevant to that combined activity that the brain does.
So the main focus is really to draw emphasis to the fact that dementia is preventable. With our dementia risk calculator, what we found is that nearly 40% of the risk factors associated with dementia could actually be prevented through modifiable behavior. So those are things that are related to smoking, your diet, looking at your physical inactivity, mental health, as well as stress. So by focusing on those risk factors, we think that we can actually reduce the occurrence of cognitive decline in the future and dementia cases.
So the Brain and Mind Research Institute is a fantastic institute where it bridges researchers that are focused from the bench side to researchers that are more applied and in clinical settings, and it allows us to collaborate with one another. That is often a limiting factor in research because we tend to work in our bubbles, or we will work with collaborators we already know, but it's difficult to reach out and create these new collaborations. But the Brain and Mind Research Institute has really facilitated these partnerships and collaborations that has sped the research progress in an exponential manner.
So good evening, everyone. Thank you all for joining us. Bienvenue à toutes et à tous. I'm Ruth Slack, and on behalf of the entire team, I would like to welcome you to Brain Health Awareness Week, hosted by the University of Ottawa Brain and Mind Research Institute. And the objective of Brain Health Awareness Week is to raise awareness of brain health and mental health, knowledge that is critically important to all of us to empower us to look after our own health and the health of those around us. Also, during Brain Health Awareness Week, we'll have the opportunity to learn about the latest research that's happening at the University of Ottawa Brain and Mind Research Institute. And as you saw in the opening video today, the Brain and Mind is one of the largest neuroscience institutes in Canada that brings together leading researchers from hospitals, faculties, institutes across the entire city of Ottawa to work as teams and to focus on understanding and developing new treatments for devastating neurological disorders. And working together as teams, as well as engaging patients and the community, is really the key to taking the research to the next level, to accelerate discovery and to turn those discoveries into tangible treatments and practice. And so now, to officially open Brain Health Awareness Week, we're very proud to present a short opening video from Dr. Mona Niemer, who is Canada's Chief Science Advisor, who's also a professor at the University of Ottawa, and has a long-standing commitment to build health research in Canada. So now let's listen as Dr. Mona Niemer opens Brain Health Awareness Week.
Bonsoir tout le monde. Hello everyone. It's a great pleasure to welcome you all to the kickoff of Brain Health Awareness Week. A healthy brain is essential for living a long and full life. And this week provides a unique opportunity to learn about important discoveries in brain research, innovative treatments, and ways to ensure equitable access to the best brain health care available. Le cerveau humain est à la fois complexe, malléable et très sensible. Les troubles qui affectent notre corps affectent également notre cerveau et vice-versa. Ainsi, les troubles du comportement et les maladies neurodégénératives ont une incidence sur notre santé mentale et physique. Chez les enfants et les adolescents, la santé mentale impacte le développement physique, affectif et cognitif. From depression and anxiety to stroke and Parkinson's disease, Problems with our brain affect how we function, feel, think, and behave. To feel and be healthy throughout your life, we need to promote and preserve brain health. The COVID-19 pandemic is a stark reminder about the importance of taking good care of our brain and mind. Canadians are now reporting increased levels of stress, anxiety, and loneliness, and have a harder time accessing services for dementia, prevention, and care. Unfortunately, the toll is not equally distributed among Canadians, with the heaviest burden falling on our most vulnerable, especially our youth and our seniors. We need to double our efforts in prevention and healing, and for this, we need research, and research in turn needs partnerships. Les meilleurs établissements de recherche à travers le Canada, comme l'Institut de recherche sur le cerveau de l'Université d'Ottawa, s'illustrent par leur collaboration de recherche pluridisciplinaire et leur partenariat multisectoriel qui permettent d'accélérer les découvertes et leurs applications au bien-être de toutes et de tous. En ce faisant, ils forment également la relève. Ces jeunes chercheurs, travailleurs de la santé et innovateurs dont nous avons besoin pour assurer un avenir meilleur. Brain research is the path to prevention, treatments, and hopefully one day cures for brain disease. It's about ensuring a better quality of life for all Canadians. Thanks to all the researchers and volunteers who are invested in this important journey and who are working tirelessly on raising awareness of brain health. Bonne semaine de la sensibilisation à la santé cérébrale. Happy Brain Health Awareness Week, everyone.
And so we thank Dr. Mona Niemer and her entire team for all the work they do in promoting health and medical research in Canada. So now, before we begin tonight's session, we have a very exciting announcement to make that really exemplifies how collaboration and partnership can drive research. Today, we announce the appointment of a new research chair, the University of Ottawa Brain and Mind, and the Briere Research Institute Chair in Primary Healthcare in Dementia Research, which is awarded to Dr. Frank Knopfel, who is a physician at the Briere Memory Program. He's an associate professor in the Department of Family Medicine at the University of Ottawa, and who will be speaking tonight. And this chair was made possible by the partnership between the University of Ottawa Brain and Mind Research Institute, the Department of Family Medicine, and the Family Medical Associates to enable our top clinicians and our top scientists to focus on their research programs in dementia, dementia prevention, treatment, and care. And we also have with us tonight another recipient of the Brain and Mind Briere Research Institute Chair in dementia research, and that's Dr. Amy Xu, who you've all seen in the video. Dr. Xu's recruitment was made possible through this joint research chair program in primary care in dementia. And this research program is important to all of us because I don't think there's anyone watching tonight that doesn't have some kind of lived experience living with dementia, either a family member, a close family member, a friend, a relative that haven't felt the devastating effects of dementia. And this is a research field that we plan to develop and expand our research capacity to really meet this urgent need. So congratulations to our research chairs, Drs. Amy Xu and Frank Knopfel, and we're really looking forward to hearing you speak tonight. And now to go on to tonight's session. Tonight's session is focused on addressing the crisis of healthcare inequities and how this affects our most vulnerable, including minorities, including seniors, and how this actually impacts brain health, including dementia, dementia prevention, and mental health. So during this session, I'm sure you'll have lots of questions or comments. Please feel free to submit your questions and comments into the chat, and the moderator will take these questions and present them to the panel. And we're very proud to say that tonight's event will be jointly hosted by Deloitte, who has a commitment to improving seniors care and healthcare equity worldwide. You will hear from leaders in this field, including David Rabinovich, who is a senior manager at Deloitte, and our moderator. So it's a pleasure to now introduce our moderator, Michael McFall. He is a partner and a board member and the National Life Sciences and Healthcare Leader at Deloitte. He's a thought leader in promoting healthcare equity and wellness in our society. So welcome, Michael. It's a real honor to co-host this session with you and our partners at the Briere Research Institute.
Michael, you're muted.
Sorry, I was on mute. My apologies. Thank you very much, Ruth, and appreciate the introduction. It is absolutely a pleasure to co-host the session this evening. The topic, as Ruth said, is addressing the crisis of healthcare inequities and how this impacts brain health and mental health, particularly in our most vulnerable. More importantly, we'll discuss what steps we can take to promote equity in Canada and abroad. This topic, brought to light during the pandemic, is really an area of mutual interest to our healthcare team at Deloitte and the University of Ottawa Brain and Mind Research Institute. And as we look to improve health outcomes for Canadians from coast to coast, over the last 18 months, Deloitte has worked closely with pandemic response teams on issues related to PPE, testing, vaccine management, population health, and many other areas. And most recently, we've introduced a set of services to support seniors, and whether that's people living at home, in a retirement residence, or a long-term care facility. And we've developed an alliance now with University of Ottawa Brain and Mind Research Institute to help bring the important research that they do on seniors, dementia, and mental health to the forefront of our market offerings. So very exciting. And today, we're going to hear from 4 leaders in the field of health equity, and we'll talk about a series of related topics. The first is health equity, looking at social determinants of health and the impact on mental health in seniors. The second topic we're going to cover is the whole question of equity and access to care and lessons learned coming out of the pandemic. The third topic will be around technology-assisted memory care. And the fourth and final topic will be access to health services in memory care, outcomes in minority groups. So it's a pleasure to start to introduce our panelists. I'll introduce them as they speak, and I'm going to start with my colleague, David Rabinovich, who is a senior manager in our Deloitte Monitor team. And David's going to talk to us about the broader theme of health equity and the social determinants of health and the impact on mental health in seniors. David, over to you.
Michael, thank you for the wonderful introduction, and thank you to the team for the opportunity to speak with you all this evening. I'd like to start with kind of how we view health and health equity. And on the next page, Candace, you'll see a bit of a definition that we often start these conversations with. We really believe that health and health equity extends far beyond access to care. It's really the ability for everyone to fulfill our human potential in all aspects of health and well-being. When we talk about health and well-being, we take a pretty broad notion of what that means to all of us. We see health really as an overall state of well-being. It's not just our physical or our clinical health, but it's really our mental, behavioral health, as Michael and Ruth were talking about, our social health, our emotional health, our spiritual, and even our financial health. And we recognize that it's influenced not only by the healthcare system, our access to, our quality of, our affordability of healthcare, but also by the social, economic, and environmental factors that many talk about as the social determinants of health. We'll talk a little bit about kind of how we view those elements shortly. But before we do, we also have to recognize a multitude of factors that come into play. We've talked about healthcare, we've talked about social determinants of health, but there's also a meaningful relationship with racism and other biases within and outside of the healthcare system. And so the conversation around health equity and the social determinants of health has to recognize the inequities that are pervasive from those perspectives as well. If you move to the next slide, we'll highlight what we really talk about as, excuse me, the social determinants of health, or what we at Deloitte and others have started to term the drivers of health. And what you see on the screen is what we kind of call our drivers of health wheel. We decided a number of years ago to use the terminology of drivers of health instead of social determinants of health, because we found that social determinants of health kind of really felt deterministic. And when we were talking to communities and to families and to individuals around the country and around the world, we really found a pretty adverse reaction to some of the phrasing. And we found that drivers implies much more agency and really alludes to the idea that addressing health requires that holistic approach. We put equity in the middle of the wheel, as you'll see, and surrounded it by a multitude of factors and categories that really impact health outcomes. I'll highlight a few of the categories and share just a couple of data points that bring it to light. But before I do that, Michael, I'm not sure if you had a question you wanted to jump into that morning. I saw you jump off mute.
Yeah, David, I was just curious. I know we've talked about social determinants of health versus health drivers. Are there any other organizations that you're aware of that are starting to use the term health drivers, and why?
You know, we're seeing a number start to use it. There was actually an interesting study that recently came out in a U.S. medical journal that looked at what Blue Cross of North Carolina and a pretty interesting research institute called the Health Initiative have been doing, where they've been going around and conducting focus groups and asking communities, what do you need to be healthy, and how would you allocate capital to do so? And they found a meaningful adoption of the term, and we've started to see it show up more and more in the literature and also in the public domain. So I think there's starting to be a bit of a shift here, which is exciting to see.
Excellent.
So let me highlight just a couple of the categories. If you look at the outer part of the wheel, the environmental, the economic, and the social ones. When you think about environmental factors, this is the section in green, containing things like food, the infrastructure that we surround ourselves with, and our physical environment. You know, we know, for example, that LGBTQ adults in the United States are twice as likely to experience food insecurity during the pandemic, and I don't think that's a US only phenomenon. We know that climate change, which is a highlight of the conversations happening at COP26 around the world this week, disproportionately impacts certain communities and also generates nearly $1 trillion in healthcare costs. Think about things like cardiovascular disease and respiratory ailments. You know, burning fossil fuels releases particles into the air, and we know that communities that live closer to those facilities certainly suffer a disproportionate burden of health impacts from that perspective. When you think about some of the economic drivers of health, this is the blue section on the top right, including things like the economy, about wealth and employment. We know that families with single women have heads of household, about a quarter of which experience poverty, versus only about 10% for families with a male head of house. You know, we know that wage equity is certainly a huge topic at the moment. More than 55 million full-time working women earn about $500 billion fewer dollars than male counterparts only a couple of years ago. And so you really start to see kind of the magnitude of how these economic issues really have an impact on our health issues. And then finally, you know, when I think about the social items at the bottom, that's a little bit of that teal color, including safety, connection, and education, some of the things that are so important to the work that the team is talking about tonight. You know, we know about 1 in 4 women will experience some kind of interpersonal violence around the world at the hands of their current or former partner. So safety has significant impacts on health outcomes. In Canada, for example, of people over 65 years of age, the population of seniors that we're talking about here, you know, almost a third of those reported with elementary education said their health was only fair or poor. And only about 7% of people who had post-secondary education said the same thing. We know that the health impacts of isolation is associated with about a 50% increased risk of dementia, and poor social relationships characterized by isolation or loneliness has about a 30% increase for risk of heart disease or even stroke. And so all of these drivers come together and really impact the health outcomes and experiences, not just of our individuals, but of our families and communities. And you can really see the range of impact around that. And what it results to is pretty staggering disparities in things like how long we live. In Montreal, for example, there's an 11-year difference in the lifespan between the wealthiest neighborhoods and the poorest ones. As we move to the next page, you know, core to our perspective, and I think what we're seeing many leaders really start to tackle, is this recognition that certainly, you know, we've talked about health equity, and addressing the drivers of health as the right thing to do. It's a moral imperative. But there's also real economic and a business case to be made here that will not just save lives, but will drive more affordability in the future. I assume we're all kind of in agreement that this is the right thing to do, but oftentimes we find that some folks need additional context around the economic impacts. This is US data, but you can imagine it being very generalizable to the Canadian context. And when you look at it in a whole, not to highlight one specific example, but disparities cost, at least in the US, about $100 billion in excess medical costs on an annualized basis. And we estimate actually that if we really addressed the disparities that we've been talking about, our economic output would increase by about $2.7 trillion if racial equity came to being. But you start to see that's the macro level, but there's also very specific issues on the page here that really kind of bring home the urgency to act. And I think what this also does, Michael, is it helps kind of debunk the notion that this is just a public health issue and just a moral issue, and it's not really something that everyone has a role to play. So wanted to kind of share a little bit of that kind of integrated view with you at this point.
And David, when you think about the actions that are being taken leading to sustainable impact in communities, how does that impact get multiplied or scaled within a particular community or across a nation?
That's a great question, Michael. And Candace, if we move to the next page, we've been really advocating for a bit of this model around how do you move from understanding that this is the right thing to do into really taking discrete and specific action in a sustained fashion to drive change. We refer to this as our kind of 4 domains of action, and what we're advocating for, what we're suggesting and recommending is that there are 4 discrete areas where leaders can really invest, they can inquire, and they can commit. There's what you can do within your own organization with your people. Do our people have what they need to be healthy? I think the pandemic has shown us more often than not that's not the case. We've seen large companies inside and outside of healthcare, even some universities start to measure how much drivers of health burden do our employees and does our workforce experience. And pre-pandemic, we were seeing rates of about 27 to 33%, which is pretty staggering, and I've got to imagine that's gone up. There's a whole notion of, are we doing everything that we possibly can through our products, through our services, whether we sell carrots or whether we sell cookies, to make sure that we are driving as much equitable health outcomes as possible? How are we ensuring that our offerings are generating health? Third, there's a bit of a fundamental reimagination of what role companies and organizations play in the community. History and fantastic records of great philanthropy work, but there's more that we can see leaders to do to really kind of drive and transform the physical communities where they recruit, where they operate, where they invest, and where they play a significant leadership role. And then finally, none of this is done in isolation. And I think to your question on sustainability, really recognizing that there's an ecosystem, there's a set of partners and actors and organizations and influencers to start to bring together and point them towards a common goal. How are we really using all of our ecosystem power to amplify impact and to bring the right community together to do it? And all of this, Michael, to your point on sustainability, requires that we kind of reimagine the relationship between healthcare and the community. This is really a much more of a collaborative process I think many have done in the past.
Thank you very much, David, and thanks for sharing your thoughts. As we come to the end of the session, we'll have an open Q&A with all of our panelists. So thank you for your piece. I'd like to turn now to our second speaker, Dr. Heidi Sveistrup, is the CEO and Chief Scientific Officer for the Briere Research Institute. And Heidi's going to speak to us about equity in access to care, the lessons learned from the pandemic. Heidi, over to you.
So I hope you can hear me and that my slides have come up properly. So that's great. Thank you very much, Michael. And thanks for the invite tonight to speak to this topic. While we're meeting here today on a virtual platform, I want to start by paying respect to the Algonquin and Anishinaabe, people who are the traditional guardians of the land on which I work and live. And I want to acknowledge the longstanding relationship with this territory, which remains unceded. So David's already provided us with important data regarding the social determinants of health and inequities faced by older adults and Canadians in general. And we saw that pre-COVID, Older adults were already at high risk for poor health outcomes, social isolation, loneliness, and COVID-19 has really served to magnify many of the inequities and highlighted a number of challenges that we need to address. A major impact that we're all aware of is the disproportionate vulnerability to the virus for older people. The early impact of the pandemic as the virus made its way into long-term care, for example, was chilling. Dr. Xu, who will be speaking later, published some of the earliest reports in Canada, highlighting the beginning of this impact and the pandemic-related challenges in access to resources, workforce, knowledge, infection prevention, and other issues compounded the risk in long-term care specifically. The initial response was to shut down in order to slow and stem the progression of the virus. And this led to increases in social isolation and loneliness that we continue to document and work to mitigate. But social isolation and loneliness in older adults is not a COVID phenomenon. For example, prior to COVID, Great Britain had established a national commission on loneliness. And here in Canada, we were seeing increased focus on social prescribing in our healthcare sector. COVID also highlighted challenges for healthcare delivery and similarly, the pathways for populations to access services. So one of the first things that we saw was that healthcare shifted rapidly, and there were significant increases in the use of telehealth and the use of telephones and digital technologies like video conferencing. And these approaches are not going to disappear. There are advantages associated with this shift, but additional challenges were identified. So health services were now being delivered directly to where people lived, but this posed a challenge for people with little to no access to the internet. In some of our recent work in telehealth and delivery of telerehabilitation, we've identified the need for research participants to be supported with hardware and internet access in order to participate in studies. So you can just imagine that the similar impacts are being felt for healthcare delivery itself. In some studies, some of our studies, up to half of the study participants required at least some additional basic hardware. We've also identified the need for significant pre-study educational sessions that addressed some of the missing technical and digital literacy skills needed by not only our older adults, but also healthcare providers. In our studies with individuals with some cognitive impairments, either due to MCI, brain injury, dementia, we also identified the need to support the digital literacy and technical literacy for families or care partners. I'll expand a little and talk about how our work and that of others is addressing each of these challenges. So our research into telehealth and virtual care has identified many benefits to the provision of virtual care, including convenience, timeliness, and safety. We've demonstrated effectiveness of telerehab programs for individuals who can access online programming on demand and at significant distances from the therapists who are delivering the programs. Across the country, we're also seeing quicker discharges from hospital with patient monitoring at home, supporting pain and other symptom management with equally effective outcomes. But the potential to increase the digital divide remains. So in 2020, the vast majority of Canadians, so over 90%, according to data from Stats Canada, had household internet access through a fixed broadband connection. And this proportion has been relatively stable since 2018, so pre-pandemic. But when reviewing age-specific data, although household internet access among those aged 65 and older increased over this period, the numbers are still well under the Canadian average, going from 71% in 2018 to only 76% in 2020. So our older adults are being left behind. At the population level, when asked why people did not have access, the majority of Canadians reported that they had no need or interest in a home internet connection if they didn't have it. But 26% reported that the cost of internet services and 13% cited the cost of equipment as being the reasons that they did not have access to the digital platforms. The differences in connectivity also remain depending on where Canadians live. Nearly all Canadian households in a metropolitan area will have home internet connections, but this is compared to less than 90% of those living outside of urban areas. And this highlights the important challenges that we see for access to the digital platforms. Access to hardware. Sorry, go ahead.
Sorry,
go ahead, Michael.
I was just going to ask you, so you talk about the financial impact on seniors, and the fact that, particularly in rural areas, they may or may not be able to afford some of the technology that they need. What about the whole question of digital literacy? Like, how do we help individuals improve in that area and develop the literacy that they need to be effective?
You read my mind there, Michael. So digital literacy is really critical. And I'll take it back a step. And so access to the hardware and infrastructure is often the response that we take when we address the move to digital health. We often say, well, people aren't accessing because they don't have the equipment, they don't have the infrastructure. But that's only the first step. Once you have the infrastructure, once you have access to the technology, so you need the equipment, you need the resources to access digital services, but equally important are the technology and digital literacy skills that in order to use the infrastructure safely. And so seniors are here again being left behind. And this causes more isolation and makes it even harder for them to access opportunities and services. So I can just give you a personal example. My parents moved from one province to the next province. And so they had to go through all of this rigmarole for getting new health cards and all the rest. They didn't know how to do that, but they were not at the time digitally literate. They did not use computers. But they didn't know where to go to get the information in order to then do what they needed to do to get their new health card and all the rest. Everything has now been moved to digital platforms. And so this is really exacerbating some of the issues that we have for older adults. Learning the fundamentals of using the internet is a gap that exists, and more attention to and funding is being devoted to digital literacy, but there are still important vulnerabilities with older adults. And so one example, in 2015, so this is pre-COVID, an American group published some results from a randomized control trial that introduced laptop computers and internet access to improve loneliness and social isolation in older adults. The individuals were recruited and spent 8 weeks participating in an intervention involving training on laptop computers. And the effects of the information and communication technologies on life satisfaction depended on attitudes towards ICT. Older adults who grew more confident about using information and communication technologies to communicate felt more socially supported, and their overall life satisfaction grew higher over time. So introducing ICTs is not a panacea, but it really depends on training and the time for a person becoming comfortable with these technologies. And a recent study from our group that was led by Jennifer O'Neill, one of my PhD students, demonstrated very similar findings with adults post-moderate and severe brain injury. So very different lived experience were reported, with one participant saying, at the beginning of the program, I wasn't sure because I'm like a dinosaur with technology. I'm not technical, it scared me, but now it is going well, very well. So it was clear though that the 30 to 90-minute pre-intervention education sessions that each dyad completed was critical for not only the video conferencing system, but because the intervention that she was studying was for rehabilitation of balance and mobility, participants also had to understand things like camera positioning for each exercise. Virtual home safety assessments had to be completed and virtual review of the exercise programs. So it's not just about learning how to use a computer, it's about how to use it in the appropriate fashion. I'll leave you with this other example. So there are many individual characteristics that will influence the successful use of digital technology by older adults. And the healthcare provider has to be made aware of this. So we just completed a study at Briere of a rapid hearing screening tool called Shoebox, which is an Ottawa company. And these individuals, our older adults, were being provided with geriatric rehabilitation at Briere. There were significant challenges that we faced when we started this work. And the most important was trying to implement the new technology when we were hit with a pandemic. But the pandemic also showed us some reason for why we needed to do this work. People, both our patients and our providers during the pandemic, were wearing masks. So we could no longer take advantage of seeing a person's face when listening, and voices were muffled. So this created even more hearing challenges. Our outpatient geriatric program transitioned to virtual care, telephone and video programs. And the hearing screening tool identified that almost 75% of our older adults had reduced or very reduced hearing loss. And more important was that half of them were undiagnosed and over a third were surprised with the diagnosis. So we haven't documented the impact of hearing loss on remote assessment and care, but it appears evidence that that impact will be significant. So the technology and digital literacy challenges are on both sides. Our current work is focusing on technical and digital literacy that are needed by healthcare providers and who are using information communication to document and assess patient status, as well as for delivery of healthcare services. Thanks, Michael.
You're welcome. And just one other question, Heidi, you referenced the question about hearing. I know that you were looking at virtual care before the pandemic even came into being. What are there any other factors that you've recognized as being problematic in virtual care?
Yeah, so it's really interesting. When we started with our virtual care work about 15 years ago, we set it up very much like a research study where patients would come in and we would assess and then we would deliver, because we were very interested in understanding how the delivery of interventions on a virtual platform would work. When COVID hit, we realized that we could no longer have patients or participants, study participants, actually come in to be assessed. So right away, the platform shifted in the way that we were actually delivering care. So what we had to do was switch some of the work that we've been doing now to addressing outcome measures with the goal of identifying new means of assessing and diagnosing. So we know many of the standardized tools that we use don't lend themselves to digital platforms, and the integration and the use of new technologies like wearables and ambient sensors, such as the work that Dr. Knoffel will speak about, will be really important alternatives for virtual care delivery.
Thank you. Thank you very much, Heidi. So now on to our third guest speaker, Dr. Frank Knoffel, clinician at the Bruyere Memory Clinic and associate professor in the Department of Family Medicine. And Frank's going to talk to us about technology-assisted memory care, new strategy to bridge the gaps. And I must say, as part of the intro, I had the opportunity just before COVID came to visit the Bruyere Center and some of the great technology you have implemented there in the seniors apartment, if you will. So fascinating. So over to you, Frank, and I welcome a little bit of an overview for us.
Thank you very much, Michael. So when people think about technology for memory care, they might see this picture here. So this is from our lab where we were looking at EEG and looking at how brain waves change with cognitive decline a bit. But I'm going to try and turn it around, like Heidi said, and talk about technology more embedded in the environment. So before I begin, I'm going to talk a little bit about my personal experience clinically with dementia and COVID-19. So dementia obviously is a disease of the brain where we have impaired memory and difficulties with speech often and executive functioning. And it's severe enough to impact our day-to-day living. So you can imagine how difficult it's been for all of us to get adapted to COVID-19. Imagine what it was like for people living with dementia. So the first thing is, of course, isolation was imposed, and rightly so. The government and institutions said, we need to keep infection out. And so we're going to sort of shut the door to everything. And for those of us that could make sense of that, it was hard enough. But for those that could not remember why my children aren't visiting, why my home care provider isn't coming anymore. You can imagine this just simply amplified the challenge. Then there was isolation that was self-imposed. So of course, the person living with dementia and their spouse were afraid to have people come into the house. So they would, if they hadn't already been canceled by government rules, then they canceled their home care. They told the family to stay home, especially if these families had young children that went to school and exchanged viruses with, hundreds of other kids. So all of this, of course, ended up again with more and more social isolation, and the social stimulation is so important for people with cognitive impairment. As Heidi mentioned, there was a whole different type of communication that happened. So finally, someone from home care arrives, but now they're wearing big glasses, they're wearing a mask and gloves and a gown. I barely recognize who is providing my care. So these are all strangers, even though they might be people I've seen before, but they're strangers to me because of my cognitive impairment. And because they're now speaking through a mask, I may not hear as well, so I don't understand, and I'm already having difficulty making sense of my world. So now if I don't hear what the person is telling me, I'm of course even more disadvantaged. And so decreased social activities, as I mentioned, be it people coming or us going places, it was severely curtailed. And so what happened, of course, is that these people with cognitive impairment, they got more disoriented, they got more perturbed, and their behaviors changed. But at this time, the health system essentially was reduced so that there was nowhere to turn. And Heidi mentioned earlier that before the pandemic, there was already a large disparity between technology acceptance of younger and people and older adults. And you can imagine for someone with cognitive impairment, learning a new technology is by definition one of those things that are extremely difficult. And so the impacts, of course, were this fear of going to the clinic. So patients didn't show up at our clinic, even when the hospital was open, because they didn't want to go to a hospital because the hospital, of course, is full of viruses. This increased the number of crisis calls. There was a parallel increase in the use of medications simply because that is the only way we can deal with behavior change, even though we know the behavior change is due to a social environment. We often had to turn to medication, unfortunately, for this. And this led to much more hospitalization and unfortunately a lot more death in the population of people with cognitive impairment, even those that didn't actually catch the virus, simply because of the indirect impact. So this last year and a half, I've seen more dramatic decline in my patients than I had in the 15 years previous to that.
Frank, there's a great question here from the audience. Dorothy Ann from Ottawa asks, is there very much research on how people age with technology? My father-in-law taught computers in high school, early convert, used personal computers and iPads, but as he got older, he had greater difficulty with, and when interfaces changed, software got updated, tools were required, etc. So how can we moderate this issue?
Yeah, so that's a great question. So unfortunately, as we age, our cognitive ability does decline a little bit. Obviously, if we age with dementia, it declines much more dramatically. So it's kind of ironic that even the people with a lot of lived experience with technology in their younger days, as we age, we drop that ability. We're less likely to take the cutting edge, and we're more likely to sort of stay with the things we know. And what we really need is to have more user-friendly interfaces. We need dementia-friendly technology, if that makes any sense at all. But that's the kind of thing we're looking at developing. But it's an excellent question. When we need the technology most is when we have the hardest difficulty with adapting to that new technology.
Thank you.
So my research is in the smart home technology is the one I'm going to present today. So thinking about sort of the simplest way of connecting people is, as Heidi said, this sort of idea of a video visit, be it, you know, an iPad and I can see the grandchildren that can't come to visit me, or formal medical visits. And we know from an AgeWell and Veronic's poll that 50% of older adults did have virtual medical visits during the pandemic. But that means that 50% didn't. And chances are that the 50% that didn't had a lot of more people with cognitive impairment. So for me, sort of the basic home that sort of goes beyond the telephone use, which presumably everyone has, then we sort of go to video visit. That's sort of the next level to sort of a smart visit. Level 2 for me, smart home technology, is one with sensors in it. So we've been doing this for the last dozen years or so. We've been putting sensors in people's homes, motion sensors, door sensors, temperature sensors, all that were sort of created for the alarm industry, but we sort of turned them around and looked at how we can use them positively for older adults. And so if you have video visiting capability, you can visit while the camera's on and while you're chatting. With the sensors, you can continue to monitor activities within the home. So is the person getting up in the usual time they get up? Have they opened the fridge door and had the sort of started breakfast at the usual time? Have they have they opened the window and then close the window when it's time to close the window, at the end of the day? So that's sort of the unobtrusive kind of sensor. Nanny cams, of course, are a little bit more intrusive because now you're sort of watching what's going on in the home. And of course, you can't put nanny cams in every room for obvious reasons. However, I'll give you just an example of some of the challenges, right? So when you want to do a call through, let's say, one of the smart home technologies that you have. So you have, let's say, Amazon in your home. So it's quite simple. We know that you go, hey, Alexa, call my daughter. The problem is when you have cognitive impairment, remembering those keywords, hey, Alexa, isn't always there. And we can stick a little poster on it and hope the person reads it, but it may or may not work. So I had a family that had a nanny cam, and whenever motion was detected in grandma's favorite chair, then they connected the video to look that she was there, and then they talked to her, and then they, through that speaker, said, hey, Alexa, call Susan, so that Alexa would then call back to the daughter who was on the nanny cam, right? So just to show how right now the technology, we need sometimes two technologies to get the one to work. So we're not quite there yet in that user-friendly type of home. But we are definitely developing the home monitoring technology, and it's really advancing well. Now, the intelligent home of the future, I think, is where we really want to go. And this is where the home actually has a little computer that processes some of this information in real time, or at least connects to the cloud and allows the processing to happen there. So the idea is that I get up every morning at 8 o'clock and I go to the bathroom, and then I go to the kitchen, and then I take out some milk and my cereal, and I have a bowl of cereal. And so the system actually learns my routines. Now, let's say that for some reason I'm not following my routine, and I'm one morning I don't get up and it's 10 o'clock and I'm still in bed. Well, this would be an unusual occurrence, and now the system would actually be able to connect and notify myself first, because I want to be the first to be woken. I don't want the call to go necessarily directly to my daughter or my son, but and so then I can choose to have the call go to my care partner or some other care professional, care provider in that sense. So this is sort of, from the simplest to getting to more science fiction and the future of smart home technology.
And Frank, when you look at this and you think of all of the technology that's available, if it was all available to seniors over the course of the past 18 months during this COVID and pandemic experience, do you think there would be different outcome? Would seniors have experienced it differently?
Well, I'm sure we would have, because the biggest challenge was that when the children and the parents, or the with especially living with dementia, or the partner living with dementia, the challenge was catching those early signs that things are going off the rails. But everyone was so, at the beginning there was no way, we didn't, other than the daily phone call, but a phone call, sometimes we don't want to worry the kids or whatever. So there's all kinds of, delays. And it was these delays, when they accumulated, that caused such a crisis. So I think that if we'd had these intelligent homes, we would have been able to catch changes earlier, and maybe make adaptations that were not requiring medication or necessarily use of a healthcare professional.
Excellent. And
so just to finish with equity and adoption, and Heidi already identified some of these nicely in her talk, the cost of technology, the installation, and the service is not negligible. These are real costs to older adults in particular. You talked earlier, and there was a good question about the experience with technology. Technology sounds scary if you don't know how to do it. Not all older adults have the supportive family, don't have the children or the grandchildren that can teach them how to FaceTime. So again, they are at a significant disadvantage. We've already mentioned the urban-rural divide. What you can get in Smiths Falls is not the same as what you can get in downtown Ottawa. And so again, we have to figure out how can we make this fair. And then there's culture. Not everyone has been historically treated well with technology, and so they might not want to be subjected to technology now. And not all technology is in all required languages, so there's challenges with the equity as well. And so just to start thinking about solutions, whenever something new comes along, it's going to be expensive, and only sort of the well-off get first dibs at it. But what hopefully happens soon is that it becomes a basic service, just like high-speed internet is almost considered now an essential service. In the same way, technology should soon be considered an essential home care service, because the home care providers will benefit from having additional information. And so it would only make sense that if we're subsidizing walkers and we're subsidizing hearing aids, that we would also be subsidizing smart home technology. That's my dream, and that's my hope. And but I know there's still some public policy work to do on that side.
Well, Frank, I've seen some of the great work that you and the team have done, and we at Deloitte, we really look forward to this working together and seeing what we can take to market and really experience that research in play. So thank you very much.
Thank you.
And now on to our fourth and final speaker, Dr. Amy Hsu, Assistant Professor at the Department of Epidemiology at the Bruyere Continuing Care, is going to talk about long-term care and the healthcare needs of those living with dementia, and specifically focused on health outcomes with minority groups. Amy, over to you.
All right, can you hear me, Michael?
Yes, we can.
Okay, perfect. And I also just want to verify that you're seeing the right screen.
We are.
Okay, that's great. Excellent. I mean, aging and technology, you don't have to be 85 to struggle with technology, right? We're all learning constantly. So good evening, everyone. Thank you so much. It's my pleasure to be here and enjoy this excellent panel of speakers. I'm learning lots from hearing from David, from Heidi, as well as from Frank. So the topic for my presentation today is looking at long-term care needs and healthcare needs of individuals living with dementia, and highlight some of the unique challenges that we have observed in minority populations. So I'll start my presentation by sharing a story. So I first learned about Gladyss Story when I was on vacation in Hawaii back in 2010. And you might be wondering why I might bring up this story. So Gladyss Burrell completed her first marathon at the age of 86. And she ended up completing 5 of 7 marathons she later attempted. Her final marathon was actually in 2010, so that was actually, it coincided with the week that I was on vacation in Hawaii. It took her 9 hours and 53 minutes to complete the marathon. I think in all of our minds, we all want to age like Gladyss. We want this fantastic life where we're living healthy without the need for home care or needing long-term care. But the truth is that the majority of older Canadians in Canada will experience some sort of functional cognitive decline in their lifetime. And unfortunately, many of us will not have that same aging experience as Gladyss. From data that we have seen using population level databases, so this is based on research where we looked at all of the Ontarians and their healthcare use in their last year of life, we found that approximately 30% of Ontarians had a diagnosis of dementia prior to death. And within this population, about 65% of them needed care in a long-term care home in their final year of life. So whether they're already in a long-term care home or they had to transition into a long-term care home in their final year of life. Compared to individuals, so decedents without dementia, which is the lower bar that you see on the slide here, only 7% had entered long-term care home in their final year of life. So people living with dementia are 9 times more likely to need long-term care in their lifetime. And in fact, when you look at the time horizon from the time of diagnosis, so from the time where identified as having dementia, within 5 years of that diagnosis, approximately half of those individuals had actually died within the 5 years. So many of us don't recognize that dementia is a life-limiting condition. And when you look at the life expectancy from the time of diagnosis of dementia versus the life expectancy of some individuals who are diagnosed with cancer, that life expectancy is actually fairly comparable. So looking at maybe not one of those cancer with higher survival rates like breast cancer or skin cancer, but when you look at the average life expectancy from cancer diagnosis, it's actually fairly comparable to individuals with dementia. And of those those who actually survive to 5 years, approximately half of that population are residing in a long-term care home. So many individuals living with dementia not only face significant cognitive and functional declines following a diagnosis, many of them actually require additional supports that are provided either through home care or through long-term care. Adding to the complexity of this issue of needing more care as a person aged with dementia, minority populations in Canada face additional challenges to accessing, to barriers to when they try to access care. As we know, we have a diverse population in Canada, and in fact, immigrants contribute to the largest proportion of population growth in our country. In Ontario, among immigrants, over 24% of the immigrant population are actually over the age of 65. And many of them will require long-term care within their lifetime. And as they enter, or as they're thinking about the types of services that they may need, English is unlikely to be the primary language for many of the immigrants needing long-term care. For a majority of this population, English was not their primary language upon their arrival in Canada. And although you might suspect that, and you might expect them to build proficiency in English as they sort of spend more time living in Canada, when the person is diagnosed with dementia, the loss of linguistic ability is one of the most common symptoms that we observe in this patient population, especially as their disease progresses from moderate to severe stages. And this can impede their ability to express their care needs and their wishes as they're receiving care in a long-term care setting. Many of them end up relying on their family members and caregivers to serve as translator when they're receiving care in a long-term care facility. And you can imagine over the course of the pandemic, this presented additional challenges when there were visitation restrictions in place on long-term care homes. And as their cognition continued to deteriorate, many patients who are bilingual or trilingual or multilingual end up resorting to their first language, so their mother tongue, as their cognition declines. So even for individuals with dementia, they have some competency to speak one of the official languages when they were first admitted to long-term care. That deterioration in cognition could cause them to resort to their primary language and present additional challenges for care providers who are supporting care patients receiving care in this setting. As you can see here, a lot of patients receiving care in long-term care setting are from sort of the Southeast Asia and East Asian countries. Unfortunately, despite the high proportion of minorities receiving care in long-term care home, in 2017, we only have 35 designated long-term care homes in Ontario out of approximately 630 facilities. So that's less than 5% of the facility that we have available in Ontario that actually cater to the specific needs of our minority population. Beyond that, when you look at the wait times of getting into one of these facilities, on the right-hand side, you see the average wait time for recent immigrants in Ontario. So this is, again, looking at population level data, looking at individuals waiting for placement in long-term care. On the right-hand side, the red bars show the average wait time for recent immigrants. On the left-hand side, you see the average wait time for long-standing residents in Ontario. So overall, immigrants wait approximately 20% longer for placement into long-term care home compared to long-standing residents. And when you look specifically at the wait time for a cultural or ethnic specific home in Ontario, that increases by 30%. So of those who are waiting for placement into one of the cultural homes where there might be staff and other residents who speak the same language, that wait time is even longer.
So Amy, just a quick question for you.
Of course.
Given all of this data in terms of linguistic issues, cultural differences, et cetera, how do we better support residents that have dementia that are living in long-term care?
Yeah, that's an excellent question, Michael. And one of the things that Frank mentioned was that we can leverage the existing technology to look at, how do we support better and safer care for dementia patients. So, for example, Frank and I are involved in this project where we're testing technology to monitor falls and wandering in patients with dementia. There's also a lot of innovative model looking at specialized care units or dementia care units are implemented in long-term care home, where they actually provide additional supports and training for the staff to care for residents with dementia. So I think a lot of the solutions that we need for long-term care potentially will have to come from outside of long-term care. So some of the things that we know are barriers to access or barriers to care include the lack of preferred care options for minority populations. There's often a lack of information that are available in multiple languages, similar issue that Frank had highlighted in his presentation. Of course, there's discordant language even when a resident is admitted into a long-term care home. So often they have communication issues with the staff members in the long-term care home. And for some minorities, this is beyond looking at the challenges for linguistic minorities. David highlighted in his presentation, we're looking at all these other social determinants of health. And when you look at other minority communities like LGBTQ2S+ communities, many of them face the fear of discrimination when they enter long-term care. So this is beyond looking at ethnicity and culture and linguistic barriers to care. But coming back to the issue of linguistic minorities who are receiving care in a long-term care home, we see a large proportion of this population. They were receiving care from their children, and in fact, many of them were living in multi-generational households prior to entry. So they're receiving care from their children who were their primary caregivers prior to their long-term care entry into the long-term care home. As you can see, a high proportion of these individuals and caregivers actually experience high levels of distress and burnout from caregiving. So this idea of the familial obligation as a cultural expectation for minority population often can actually lead to greater caregiver burnout and caregiver burden among minority individuals. And this is where, again, innovations like looking at technology and technological solutions to support caregivers in the home environment could potentially reduce some of these experiences of burnout and distress. Now, I think a lot of my research has this very doom and gloom tone to it. So I also like to end my presentation highlighting the fact that, we know dementia is preventable. And in fact, when you look at the progression of research, even over the recent years, the proportion of risk factors that have been identified as modifiable risk factors for dementia has increased. So when we look at this Lancet report that was produced and released in 2017, they estimated around 30% of the risk factors for dementia were considered modifiable risk factors. Now, when we look at their updated report that was published last year, now that proportion has increased to about 40% of the risk factors are identified as modifiable. So I think when we think about broader scheme of things of how do we build a sustainable health system, how do we continue to support individuals living with dementia, prevention is actually part of that equation, part of that conversation, which is thinking about how we can reduce the incidence of dementia, which will then in the future reduce the burden that dementia as a disease will impose on our healthcare system. So that concludes my presentation, and I will stop sharing here.
Thank you so much, Amy. So folks, now we're going to turn to a part of the session where all of our panelists will be available to answer your questions. I see we have a couple in the Q&A. So if you have a question that you would like to answer, please bring it forward. I'm going to start with one from Diane, one of our guests. Does the use of new technologies reinforce symptoms of dementia simply by replacing normal brain activity? Frank and Amy, I'm going to ask you for your thoughts. Frank, can we start with you?
Sure. It's an excellent question. So what we do know about the brain is that the more we keep it engaged and busy, the better it is. So the more we use different parts of our brain, the more vibrant our brain will remain, and the better it is for our overall health. Anecdotally, we know that people who use technologies a lot, that they will actually have a little bit of disuse in that. And some people with technology won't learn a skill that others would have learned. So I learned how to use a map. My daughters don't know how to use maps. I can lay a map on the table and say, this is where we want to go. And they'll say, no, I'm going to put it into my GPS, because so they have not learned this spatial organization, this way of seeing the world on a piece of paper. So it's anecdotal, and I think we have a lot of research to do, but I would concur that what we don't want technology to do is to replace our activities. What we want technology to do is to support our activities. So I am not stopping reading. I have, and I'm not stopping walking, but I don't have time to go to the library to pull out a book. So I'm going to look up that book on the internet. So I'm going to continue to read, which is good for my brain. And when I get home, I will do my exercise. It's just that I won't be going to the library to pick up a book. So it's not to replace, but yeah, that's where I'm going to leave it. I'll pass on to Amy.
Amy, anything additional to that?
Yeah, I would just add that I think a lot of the conversations around, dementia prevention and think about neuroplasticity is that you want to feed your brain a variety of new challenges, right? So sometimes technology can provide an opportunity for that. And we think about, everything from the ability to maintain social connections with your family members, with friends and others in your social circle, within your social network. And also some of the games that you've seen in Frank's smart apartment, where he's using it to test individuals' cognitive abilities. I think we can find ways to use technology to support that learning rather than replacing it. So just a little bit of add on to what Frank has already mentioned.
Thank you. David, I have a question for you. Just thinking about the whole question of health drivers and what they mean. Various organizations, they're complex, they're interdependent. How do we really measure impact of an individual health driver? And how do we put that big picture together for organizations to better understand?
Yeah, Michael, it's a fantastic and it's a common question. And I think we're still really trying to find a great answer, to be honest. There's been some really great work that a number of organizations have done to start to understand what's called a healthy days measure. There was a great effort in the US called Bold Goal a number of years ago, which was the number of organizations trying to raise the overall health status of a community by X% by X date, as measured by asking individuals over the last 30 days, how often have you felt mental and physical well-being? And so I think there's this notion of really kind of focusing on what individuals need to be healthy and doing it in a way that comports with their own notion of health and well-being, which I think is critically important from an equity standpoint. At an aggregate level, we're starting to see some pretty interesting measures start to shape up around how do you look at an entire community as the denominator versus a tendency to say, well, I'm only going to measure the health of the patients that I see in my clinic or the members who participate in my certain type of access or coverage, and really to say, what's the whole health of the community? So there was one organization that actually started to tie executive compensation to the percent of community members, not patients, who had a hard time accessing healthy food, which fundamentally changed how responsible and accountable an organizational leadership team was for that topic. So I think those are a few that we've seen start to really start to bubble up. I think it's also a matter of kind of cutting through the noise and kind of trying to anchor in on the signal. There's a lot of I think it's easy to get kind of paralyzed by the complexity, and oftentimes what we're talking about is hunger, is a good paying job, is multi-generational poverty, is access to high-speed internet, is things that we just know need more investment and need more consideration. And so I'd also argue that sometimes I think we get a little hung up and until we have a metric we can't act, and I would say there's a lot of action that we know we can start to take now.
Thank you for that thoughtful answer. A couple of other questions in the Q&A here. I'm interested in having access to the list of modifiable factors to prevent dementia. I walk, read, encouraging though at 69, I may be late to the real solutions myself. Who would like to take that?
I could take that. I
All
don't
right,
know
go ahead.
where the question is. Yeah, I don't know where the question is coming from. I hope it's not from one of my team members. But our research lab has developed this excellent online calculator. It's hosted on projectbiglife.ca. And it's a dementia risk calculator that looks at some of the main risk factors associated with dementia. So if you go online, hopefully that you have the support to have someone who can walk you through the calculator, but it should be fairly intuitive. We spent a lot of time actually thinking about user experience and user design. But many of the risk factors that I mentioned in that report in the Lancet Neurology Commission is included in our web calculator. And it would generate some statistics around what's your likelihood of developing dementia in the next 5 years. And I will say it's never too late because of the linkage between your cognitive health and your cardiovascular health. So if you exercise more, if you eat healthier, it has just an overall very positive impact on your health in general. So it will lower your risk for both cardiovascular diseases and dementia.
Thank you. A question, Heidi, give your thoughts. Is dementia hereditary?
Well, I'm actually going to let Frank take that one because
Okay.
he would have a much better idea about the percentage and the amount of hereditary component.
Sure. So what I tell my patients, and particularly the children of my patients, because they're the ones that are most curious about this, of course, is that you double your chances of having dementia if you have a direct family member with dementia. So what does that really mean in real life? So let's say that the average person has a 1 in 8 chance of getting dementia in their lifetime. If you double that, it would mean you'd go to 1 in 4. So that's double, and it sounds terrible, but 1 in 4 still means that you have 3 out of 4 chances of not getting dementia or passing away from something else, obviously. But back to Amy's point, right? The more you know, the more you can do about decreasing your risk. And I think it's really there. There are certain types of dementia that are more likely to be genetically linked, and others that are less. But I'm not going to go into that. But what I would say is the last part of the puzzle is if you have a family member with vascular contribution to their dementia, then even more important to modify your vascular risk factors, like Amy said.
Thank you. I'm going to do 2 rapid questions and we'll just ask for a very brief answer, but how do I get the games to help my husband to address some cognitive issues?
So it depends on where you are in the cycle. So it's really important to realize that if you are aging normally and you want to do brain activities that are good for you, those would be different than something you would give someone with dementia to do. So if you're trying to keep someone's brain active when they have dementia, and even there in the stage of dementia you're at, it will look differently. So I think, the first part of the answer is it's kind of tongue in cheek, but it sounds like, what do I have to get my husband to do? The first problem is it needs to come from him, right? You can't do a solution to someone. They do need to at least want to be part of it. But if they've asked you, hey, what can I do? Then there are certainly websites that do that kind of thing. So there are websites for dementia-specific, dementia-friendly games. And then depending, like I say, in the stage you're at, there's different things that you can do online. But I would look for evidence-based solutions as much as possible.
Thank you. And there are 2 questions in the chat in the Q&A section, and they're kind of similar. One talks about immigrants in long-term care facing language issues, but also food being served, not being ethnic. And the second question comes in the same direction, which is how do we improve access to healthy things that people need in the North, for example? So fresh fruit, vegetables, connectivity through technology. It's all expensive and quite unreliable. Who'd like to address those 2 components?
I could take the
Amy?
one regarding the immigrants' health. Yeah, I think, and recently, my researcher has been meeting with a lot of long-term care homes across the country, partly to support this report we're building, informing the long-term care standards that many of you may have heard about that we're setting nationally. And one of the challenges is that a lot of these providers are looking for solutions internally. So they serve the population that is within their geography, within their neighborhood. And they do the best they can to try to match the staffing ratio in terms of the ethnicity and the language to the residents. But unfortunately, the funding that often comes from the government doesn't provide additional support to provide that training, to provide linguistic support, to provide additional resources that these homes might need. So that's part of the work in terms of doing research that can inform policy to highlight the importance and the gaps that exist in our system, and thinking about additional supports that government funding could actually introduce to make it easier for immigrants both to access long-term care, but also to receive the services they need within long-term care homes.
Okay, thank you. And the last question I'll ask, and I think, Frank, it'll go to you. There's a couple of questions in there about the impact of wireless technology on brain health and brain function. And I don't know if there's any correlation, but some people have said that they've been impacted by it. So the question is are there cases where that's true, and would we use more wire technology versus wireless? What are your thoughts?
That's a great question. I think that we're in early days and we need to study them longer. But what I rely on is that my engineering colleagues, that when they develop the standards, that they always look at the least dangerous. But that doesn't mean that down the road we won't find, that certain use of certain things has not been good. So I think that time will tell. The wavelengths we use are supposed to be safe, but we'll have to keep monitoring that for sure.
Fair enough. Well, to all of the speakers and panelists, thank you very much for taking the time this evening, for sharing your thoughts and helping us to understand a little bit more about seniors care, dementia, mental health, and the technologies that can support that. So on behalf of Deloitte and the rest of the group, thank you very much. Ruth, back to you.
All right. Well, thank you, Michael, for a very thought-provoking session, a great discussion tonight. And I'd also like to thank the speakers for their inspiring presentations and great panel discussion. So this session has been recorded. So if you want to see parts of it again, it'll be on our website. There are also very specific questions about dementia prevention. We have a dementia prevention website, dementia/prevention.ca, where you can access the risk calculator that was created by Amy Hsu and her colleagues. You can also get suggestions as how to prevent dementia. There's Dr. Hakim's book on Save Your Mind, 7 Rules to Prevent Dementia. So there's a lot of resources there. I'd also like to, at this point, thank the team. We have an amazing team that put this session together. Our manager, Natasha Hollywood, our administration coordinator, Candice Fortier, and our science writer, Sarah Schock. I'd also, like to thank everyone that participated in organizing this event. And if you would like more information, there's the Dementia Prevention website. There's also the University of Ottawa Brain and Mind website. You can follow us on Facebook and Twitter. And we hope that you can join us for tomorrow evening's event. And the event is Meet Ottawa Stroke Researchers, how research in our own city can change patient care around the world. So again, thank you all for being with us tonight for a great session.